A very good evening to you all. Thank you once again for choosing this platform at this time of the hour today. We are glad to have you once again for the clinical pathological case series of emergency medicine. Welcome to this forum where we sharpen each other in care of emergency patients that we see on a daily. And just a disclaimer for this session, all the content that is aired on our platform is purely for educational purposes. It does not replace your clinical acumen in care of patients. So you are very welcome to this session. My name is Anna. I'm an emergency physician, and I'll be your moderator for the day. Our session, as usual, is for 1 hour. So starting 7 to 8 p.m., we should be closing off this session immediately. Seeing we have 44 members, I'll give 2 minutes to letting more people log in. And in the meantime, as they're logging in, I'll just be passing on a few preambles before we shortly start. Once again, once you're logged in, please turn off your video, turn off your audio devices. Try to make sure that your background is clear. Do not unmute your mic as we are running this session in order to allow for smooth running of the session. Avoid any interruptions. In case you have a question, please type it in the chat. We shall have someone attend to all those questions in the chat. And where necessary, we shall ask members to raise their fingers, raise their hands, whatever you're able to raise on the chat or in the reaction section. And then you'll be selected to give us your question or your comment. Once again, you're welcome. This is a platform full of people of different cadres. Please feel free. It's a learning environment. Everyone is safe. It's a safe space. All answers are correct. Don't feel like you need to be a pro to be able to answer. What you think is wrong today might be what you think is correct today might actually be wrong because you did not talk about it. So please feel free to pause your question in case something is not making sense to you, and it will be surely clarified. Yes, you are welcome to this session once again. 2 minutes past 7 p.m. We shall dive into our session. And just a brief introduction of the people that we have on our session. We do have Anit, who will be our case presenter for the day. He's a medical student, year 5 at Makerere. And then we have Nachanzi Mebo, who will be our pre-hospital presenter for the day. We do have our expert, Dr. Guloba Umar Rashid, an emergency physician, who will be our session expert for today. We are excited to learn from him and from his expertise. And our session, basically today, we are looking at our catchphrase is a patient who is not breathing. So open up your mind to learn from this case for today. 3 minutes past 7, I open up the session. You are welcome, Dr. Anit. Just give a brief introduction of yourself in 3 seconds, and then drive us away.
Thank you, moderator. Good evening, everybody. My name is Ankit Kalani. I'm a fifth-year medical student currently studying at Makerere University, and I will be your presenter for today.
Thank you. You are welcome. Mabel, are you ready to take us through the pre-hospital session of this case today? Use 3 seconds to introduce yourself, and then you can carry on.
Good evening, everyone. My name is Mabel Nachanzi, a student at St. Michael Rubaga Hospital Training Schools, SEC, Year 2, Semester 2. So, and in this session, I'm going to be the pre-hospital presenter.
Okay, you are welcome. So, team, we do have a 48-year-old male who was involved in polytrauma and is being transferred from the scene to hospital. So, Mabel, take us on the pre-hospital care of this patient, please. Mabel, kindly unmute your microphone. We cannot hear you.
Are you able to hear me?
I can hear you bits, but you're breaking. Kindly unmute your microphone. You've muted yourself.
I'm sorry, let me go on. So patient presentation and transfer details. It's
Mebo, you've muted your mic again.
I'm so sorry. I'm so sorry. So patient presentation and transfer details. It's a 48-year-old male managed for polytrauma following a road traffic accident. Initially managed from a low-level facility and referred to a high-level facility for advanced trauma care. Using a Type C ambulance, crewed by 2 EMTs and an emergency driver. In preparation for the transfer, the following equipment and requirements were needed. We needed diagnostics for continuous monitoring along the transfer. We needed PPE for the crew. We needed airway adjustments and a suction device to back up our airway. We needed an oxygen cylinder and a non-rebreather for oxygen therapy. We also needed IV cannulas and IV fluids to support our circulation, and a C-collar, splints, and a spine board and its accessories for immobilizing. So when we are picking up a polytrauma patient, we focus on background and mechanism, ABCDE threats, and head to toe reassessment. In background and mechanism, we identify the mechanism of injury, time since injury, and we identify injuries and interventions done by the referring hospital, and also we assess our patient for stability prior to transfer. In ABCDE threats, in airway, we look out for airway obstruction, reduced gaseous, and C-spine risk, as any drop in consciousness might compromise our airway. In breathing, we monitor for respiratory distress, and also since our patient had a chest tube, we ensure patterns as blockage can rapidly worsen breathing. In circulation, ongoing bleeding, hypertension, shock were key concerns, and which might indicate internal bleeding. In D, we look out for any drop in gaseous and unequal pupils. In exposure, we watch out for hypothermia, any missed injuries, bleeding, and bleeding under dressings. Then we have to do a focused head to toe reassessment, and we look out for any changes during the transfer. Head and neck, we look out for the level of consciousness. We look out for any pupil changes and collar positioning. Chest and abdomen, we listen to breath sounds, chest rise, and any abdominal distension. Pelvis, extremities, and back, we monitor for pain, bleeding, deformities, and distal pulses. So allow me to give a handover report, a ISBAL report. My name is Mebo Nachanzi. I was dispatched for an interfacility transfer of a 48-year-old male from a low-level facility to a high-level facility. Situation: it is a 48-year male being managed for polytrauma following a RTA. Background: the patient sustained blunt chest and abdominal trauma with multiple fractures of the right femur, right tibial fibula, mandible, and ribs. On assessment, his airway was patent, so during transfer, we maintained the airway patent. He had a respiratory rate of 21 breaths per minute and an SpO2 of 75% on 10 liters per minute via a non-rebreather. And during transfer, we increased the oxygen to 15 liters per minute, and we achieved an SpO2 of 94%. He had a heart rate of 147 beats per minute, a capri fill less than 2 seconds. He also had warm peripherals. He had a BP of 90/60 and echo and reactive pupils. On exposure, he had a chest tube in, draining blood, and a urinary catheter in, draining yellow urine. Finally, we recommended the following recommendations: reassessment of the chest tube and urinary catheter, chest and right lower limb imaging, and continuous monitoring of vitals. That concludes my presentation. Thank you.
Thank you, Mebo, for giving us a preamble of what happened to this patient in the pre-hospital period. Yes, at this moment, would want to see bring in our expert, Dr. Umar Rashid. You're welcome. How do you feel about what are your initial thoughts about this patient, and then how he was assessed in the pre-hospital period? Would you have done anything different for this patient? Dr. Umar Rashid?
Thank you, Anna. Can you hear me?
Yes, we can hear you well.
Okay, thank you very much. My name is Gulova Umar Rashid, and it's an honor to be with you. And there's a lot to unpack. So we had a 48-year-old male polytrauma patient who was being transferred from a lower care hospital to a higher care hospital. And the few things that I picked from the history was that he's polytrauma with several fractures that were noted. There was a right femur fracture, tib fib, mandible, rib fractures, and then there were also a history of blunt chest and blunt abdominal trauma. And then the signs and symptoms that you presented, I saw signs that are pointing to a shock or a pre-shock condition because the patient was tachypneic, 21 breaths per minute. The heart rate was very high, tachycardic, 147 beats per minute. The BP was low. I saw a BP of 90/60, which takes us into a shock state. So I would want to know before the transfer and during the transfer whether shock was taken care of, whether fluids were given, how much fluids were given, and then also whether they identified the source of the leakage, because the assumption is most likely we are losing blood somewhere. And since this is a polytrauma patient with multiple fractures and also with blunt abdominal and chest trauma, we could be losing blood in the abdomen, that in the peritoneum. We could be losing blood in the chest, the pleural space, the mediastinum. We could also be losing blood in the limbs because I saw femur fracture. Femur fractures are notorious for concealing blood loss, which could go, if they are bilateral, to almost 2 liters or even more. So I would want to know whether shock was taken care of, and I would want to know how they dealt with the C-spine. I didn't see anything to do with the C-spine management. I would also want to know whether blood grouping and cross-matching, and maybe if blood was given before transfer. And those are my initial thoughts. What is your preparation and approach to this patient? This is a complicated patient because it's a polytrauma patient. So many things are going on. I don't know whether we have a traumatic brain injury, but it's possible that you could be having traumatic brain injury. The reason I'm saying this is I saw somewhere a mandible fracture. Usually by the time your mandible is fractured, the mechanism of injury usually is so, like the force being impacted on your mandible is so high that most likely your brain is going to be moved around in that cranium. So it's possible that you might end up with a traumatic brain injury. So Uh, this is not an easy patient to manage, but my initial approach would be to make sure that I go through my ABCDE. I take care of the things that will kill the patient first, and then we look at the others later. Because what I know will kill the patient first is going to be the excessive blood loss, the hypovolemia because of the hemorrhage. That will kill the patient first, or especially if it is a catastrophic hemorrhage, or like if you have excessive bleeding, either from solid organ, spleen, liver, and we have 2 or 3 liters of blood in our peritoneum, that will kill the patient even faster than your airway. But also, the other thing that will kill this patient fast, which will be my urgent concern, would be the airway. Because of a fractured mandible and the possibility that we are having our airway could be compromised. There could be facial fractures and also there could be traumatic brain injury. So I'd want to take care of those 2 things and then I look at the rest later. Thank you very much.
Okay, thank you, Dr. Umar. Mabel, do you have an idea of whether the patient was managed for shock in the previous facility before being transported? If you don't, it's still okay.
Yes, and in that we administered normal saline 500 mils during the transfer.
Okay, thank you. And then there was a concern of if sequela had been put on this patient given the mechanism of injury.
Yes, it was in place.
Okay, so maybe that's something to note. Our handover did not report everything we did. Anyways, thank you so much. Thank you, Dr. Umar. So now the patient is within hospital. Dr. Anit, over to you. I'm giving you a few minutes to take us through the first session of this presentation. You're welcome.
Thank you. So we received a 48-year-old male who was previously being managed for polytrauma, which include multiple fractures and possible internal injuries, blunt trauma, especially the chest and abdomen. And this was following a road traffic accident. And on arrival, this patient developed sudden onset, difficulty in breathing, and sweating. So on our primary survey, we noted an airway that was patterned. However, this patient was in respiratory distress with a respiratory rate of 50 breaths per minute, and he was saturating at 75% on 10 liters per minute via a non-rebreather mask. He also had warm peripheries, had a cap refill of less than 2 seconds, the tachycardia of 147 beats per minute. On the disability, his pupils were equal and reactive to light. There were visible deformities to the fractures, but no one-sided weaknesses noted. And there was no glucose strip available at that moment to check this patient's blood glucose levels. On further exposure, this patient was febrile with a temperature of 38.8 degrees Celsius. He had jaundice, severe pallor. We also noted a chest tube in situ that was draining blood, and a suprapubic catheter in situ draining yellow urine.
So right about now, we have a poll that is going to run. It's running for 1 minute. And I want you to answer what are the possible imminent emergencies in this patient, given the pre-hospital aspect and then the initial primary survey that has been done for this patient. So we have 1 minute at exactly 19:20. We shall be closing this poll. Please attempt. Like I said, every answer is correct. We shall discuss the options. Yes, what are the possible imminent emergencies in this patient? So we have ARDS, PE, hemothorax, sepsis, or is it acute coronary injury? Is it AKI? Is it CVA? Is it cardiogenic shock? Is it a pneumothorax? Is it pulmonary edema, aspiration, metabolic acidosis? Is it anaphylaxis, status epilepticus, upper airway obstruction, hypoglycemia? Okay, so I do have 55 people have so far answered. Once I hit 70, we close the poll. Okay, so 50% of the people have answered. We'll end this poll. We shall get to discuss the poll results later on. Okay. Dr. Anit, over to you. Please take us through the next session. We'll discuss the results of this later on.
Okay. So after the primary survey, we took a sample history, and the visible signs and symptoms on this patient with a sudden onset of difficulty in breathing and the sweating, the profuse sweating. There were not any allergies reported to us. The medications, he had previously been given 2 units of packed red blood cells, tramadol, Dynapa, paracetamol, ceftriaxone, Clexane, tranexamic acid, metronidazole, D50, and normal saline. The past medical history was unremarkable, with no history of any chronic illnesses such as diabetes or hypertension, and the serum status of this patient was unknown. We assume this patient to be NPO for a while, and the events leading to presentation, as we have discussed, this patient was admitted as a referral from a low-end facility with polytrauma, which included blunt chest and abdominal trauma, fractures of the mandible, ribs, right femur, and right tibia fibula, following a road traffic accident.
Okay, so before we invite our expert, maybe we would love to hear from the audience. Is there anyone on top of the information that you've so far listened to as we walk through the case with this patient? Are there any questions that you do have? In case of any, please type them in the chat. Like I said before, someone is present to answer and attempt to them. Dr. Omar, so far, I think part of the history you wanted and part of the sample, some of the investigations and the intervention that have been done for this patient have been listed in the sample history. What are your additional thoughts at this point?
Okay, my thoughts going forward. The patient, first of all, is there are so many things going on because he's a polytrauma patient. And number one, the 50 breaths per minute, that means our work of breathing is very high and this cannot go on for long. So we need to find a way of reducing it. And the SpO2 being 75 at 10 liters, the very first thing I would do is to increase the oxygen to max it, 15 liters or even more. And I see if this improves on the SpO2 and 50 breaths per minute. The cap refill being less than 2 seconds is very misleading because this is the patient in shock. So we need to manage this shock, and 500 mils of normal saline being given. I don't know the weight of the patient, but if it's an adult male with an assumption of about 70 kilos or 75, ideally, if you're giving it at 20 mils or 30 mils per kg, we need between 1.5 liters to 2 liters of normal saline as a bolus to at least get us to do something to this shock state. So the fluids that were given were very minimal. And then the other history, my other thoughts, this patient they didn't tell us when the accident happened, but the fact that we have jaundice, we have severe pallor, okay, we have jaundice and the fever, gives me an impression that the accident didn't happen maybe like 12 hours or 24 hours ago. It didn't happen the same day that the patient was transferred. So we needed to know when the accident happened. So that is the additional information I would want to know. And then TXA was given. TXA helps to stop the bleeding, but there's a time limit in how much you can give the time limit on when you can give the TXA. I think beyond 12 hours, you might not get the benefit that TXA offers in reducing blood loss and the need for blood transfusion, especially if it is a TBI patient. So we need to know when the accident happened. And then there is evidence that there is blood in the pleural space because there's a chest tube. So we don't know whether it was a pneumothorax or a hemothorax or hemopneumothorax, which led to the insertion of the chest tube. So that's the information we also need to know, because there is blood coming out from the chest tube and there's a chest tube inserted. So we need to know what led to that diagnosis. Was it an EFAST? Was it a clinical examination? Or was it a chest X-ray that led? And was it one-sided or was it bilateral? And yeah, additionally, yes, so those are some of the things that those are my additional thoughts at this point. I think we can add on as we get more information. Thank you very much.
Thank you, Dr. Umar. Dr. Anit, do you want just to clarify on two things? How long ago, if you have that information, how long ago did the accident happen in terms of time, hours? And then two, if the chest tube was inserted, okay, from the history, you said it was inserted from the previous hospital. However, did they indicate clearly the indication for chest tube insertion? Yes, and then maybe this Dr. Umar will answer on the next break. Would want to know, you mentioned, you elaborated about fluid therapy in patients with shock and trauma. Maybe we'll just highlight for us the time to it, but not now. Maybe we can look at it in the next stop. For now, let's hand over to Dr. Anit in the interest of time to lead us through, and then he'll answer the questions. Dr. Anit, you're welcome.
So this transfer was done on day 5 post the road traffic accident. And when we received the patient, he had a chest tube in situ. And obviously, as I mentioned, was draining blood. So obviously the chest tube was inserted at the lower health facility prior to the transfer. And about the TXA, so most of the medications that I have listed in my sample history were given to this patient still at the lower health facility from where the patient was referred. Yeah.
Okay, just to interject a little bit. So, okay, this explains a lot because 5 days ago, so it explains the fever, the pallor, and then also it explains maybe why they gave Clexane, because it is not standard of practice to give Clexane to trauma patients unless these people were thinking now we have a coagulopathy at hand and then maybe a PE or this patient has been in one position for long. And then also it's very unusual to see tramadol, Dynapar, and paracetamol being given to the same patient. And I don't know whether it was the same time, but it's also quite unusual.
Okay, so on the referral note, it was not specifically indicated the dosages and when were these medications given. It was just listed that during the patient's stay at the facility, these were the medications that were given to the patients. And the reason I would think that they would give this patient the Clexane would ideally be for prophylaxis against DVT or a possible pulmonary embolism. again, which could be due to the polytrauma and the patient being non-ambulant for a while.
Okay, so we do have our next poll, which is going to run for 1 minute again. What are the key emergency department priorities for this patient? In the event that you have a patient that has been, like it has been showed to you, what would be your key priority management plans for this patient? You have a few options. It's running for 1 minute. And the moment we reach 50% of the people on the call, we shall end the poll. Please answer very fast. I hope the questions in the chat have been well answered. To everyone else who had a question, someone asked what was the rationale for giving Plexen. I think Dr. Anita has attempted that quite well, and Dr. Omar. And then the other question was, it was a comment on the TXA. TXA, usually literature says beyond 8 hours, but it can be like Dr. Umar said, in our setting, most of the time you receive patients who are more than that. So you can give and see if it could benefit, but literature is beyond 8 hours. Okay, so please answer the polls. We have 62 people have so far answered, that's 40%. Okay, so 45% of the people have answered. Please answer the questions. Please answer the poll. In the next 5 seconds, I'm going to end this poll. Okay, poll is ended. Dr. Anit, kindly take us through your emergency department care for this patient and take us through the secondary survey. In the next 5 minutes, you should be done with that section.
So as the ED team, the following was our intervention. We maintained patency of the airway, and as the patient was desaturating, we started them on high flow nasal cannula, giving them 60 liters per minute at an FiO2 of 94, and we were able to achieve a saturation of 94%. To maintain the circulation, we administered IV fluids, which included normal saline, 1 liter, and we also monitored this patient, especially the ECG. We encouraged feeding via a straw, as obviously this patient had a dislocated mandible, and we advised the caretakers to give them semi-solid foods like yogurt. And to manage the other findings, we gave IV paracetamol, 1 gram. We expose the chest, clean the chest tube side, redress the insertion side. As this patient was spiking a fever, we also administered IV ornidazole, 500 milligrams, and ceftriaxone, 2 grams. So that was our ED intervention. Now, on the secondary survey, the head and neck, we noted lacerations of the head, and which was bandaged. And obviously, in addition to this, there's also the obvious dislocation of the mandible. On the chest inspection, we noted the chest was moving with respiration at a rate of 30 breaths per minute with the chest tube in situ, and this patient also had hypertrophic scars near the angle of Lewis. Palpation, there was mild tenderness noted and no subcutaneous emphysema. On percussion, there's a stony dull note on the right side of the chest and a resonant note on the left side, as well as on auscultation, reduced air entry on the right side with vesicular sounds on the left, indicating possible fluid collection in the right side. On the abdomen, there were no scars or lacerations noted. Extremities, there were fractures over the right leg. Neurologically, this patient had a GCS of 15 out of 15 with pupils equal and reactive to light. The skin was warm, pale, with lacerations over the upper limbs and head.
Yes, so at this point, I want to welcome Dr. Omar again. What are your thoughts at this point?
Okay, what are my thoughts at this point? What are your differentials at this point? Okay, so my differentials at this point, apart from the hemorrhagic hypovolemic shock from hemorrhage that I think has we have attempted to correct it. We don't know the weight of the patient, and so I don't know whether the 1 liter of normal saline given was enough for this patient, especially seeing that the BP was very low. So we could still be having hypovolemic shock in this patient secondary to hemorrhage. I'm not sure where all the blood is going, but I have an idea. Number two, we have second differential would be blunt chest trauma with hemothorax. Then with the hemothorax, especially on the right. The reason why I'm saying that is because I think the chest tube is on the right, if I'm not mistaken. But also on examination, we had stony dullness and reduced air entry on the right as compared to the left. So I think we could be having blood in the pleural space on the right. It may be blood only, or it could even be a hemopneumothorax. And additionally, we have a history of rib fractures. So I don't know how many ribs are fractured. I don't have evidence. So I can't rule out these rib fractures contributing to the difficulty in breathing. And if there are more than two and there's a sediment, we can't also rule out flail chest at this moment. And then the patient has a GCS of 15 out of 15. So this may rule out traumatic brain injury, and seeing our neuro exam was okay. But I think those are my differentials. And also additionally, blunt abdominal trauma. We don't know what the EFAST would reveal at this point. So I can't rule out blunt abdominal trauma with solid organ or organ damage, especially the spleen, the liver, the kidneys. So you could have a positive EFAST because of the blunt abdominal trauma history. And then also the other diagnosis would be the fractures that have been noted in the patient, the several fractures, mandibular and the rest. The other differential would be electrolyte imbalances due to the fact that the patient has been on the ward for quite a while. Those are 5 days. And we don't know what's going on. So I don't know how the patient has been feeding with the mandibular fractures. The NG tube was just inserted recently. So we could be having electrolyte imbalances. We could be having an infective process, especially aspiration, pneumonitis, pneumonia, supra infection of whatever, maybe surgical site or the tube that was introduced or the blood which is not coming out. So an infection in the chest, either secondary to the tube or because of whatever intervention that was done. And then also the patient has a bandage. We didn't see the extent. There was the bandage removed and then the extent of the injuries on the scalp. So those are some of my differentials as per now. My management plan would be get off that bandage and see what do we have and whether the bleeding or the wounds or lacerations have been taken care of. The other thing is get the exact weight of the patient and give the appropriate fluids. I could give at 20 or 30 ml per kg as a bolus. And then also because the patient is pale, make sure that we get his HB and give him the right amount of units of blood to correct the HB. But before we give the blood, we must make sure that we stop the patient from bleeding. So we need an eFAST to see whether there is continued bleeding in the abdomen, and then whether there is a pneumothorax, and then whether we have blood in the chest, and what is the extent of that hemothorax or hemopneumothorax. So we need radiological investigations for that chest, an X-ray, an eFAST. If you have good, we could also do bloods, especially to check on the electrolyte state of the patient, and then also check of cultures. Because the patient had a fever, we want to know whether we have a bacterial or viral infection, which is complicating our picture at this moment, because we saw a lot of antipyretics being given. So, and then also we can't also rule out ARDS secondary to trauma at this point. And so antibiotics are okay, but it would be good to know, give the right antibiotics. Broad spectrum as per now, as we wait for the results of the culture, or if you have an antibiogram and you know what works in your place. Fluids, we've talked about fluids. Pain management, rib fractures are very painful, so we want to manage the pain properly for this patient. So I would think about giving paracetamol, and then I could add on maybe fentanyl, and I would avoid tramadol. Tramadol is not a very good painkiller, and also because it needs to be broken down by the liver to its active ingredient in order to work. The other thing I would want to do for this patient is on part of management. Yes, the feeding, NG tube feeding is okay. What else? I think, yes, I think that's, and then also the oxygen delivery. I saw the patient was being given 60 liters of oxygen at an FiO2 of 94. I would raise the FiO2 to 100 and then try to reduce those liters. That's a lot of oxygen being given. And try and reduce that work of breathing. Those 30 respirations a minute are still on the high side. I want it lower, because if the patient gets tired of breathing, then we might end up having to intubate this patient. So I'll do all I can to maximize and optimize the oxygen delivery such that we reduce our work of breathing, and then also do chest imaging to find out exactly what's going on in this chest. Thank you very much.
Okay, thank you, Dr. Omar. Dr. Anit, you have 5 minutes to discuss the results for your patient. And then the next 5 minutes, you will take us through what is your take-home message for this case. The differentials, you can list them as long as the one Dr. Omar did not talk about them. That which he listed, you don't have to repeat.
Okay, so he talked about the ARDS, and we can all see the reasons why. Other than that, we also thought of a pulmonary embolism. Again, the patient being non-ambulant and having a history of polytrauma, being tachypnic. Same reasons we also thought of pulmonary contusions. And as I'd mentioned, from the referral facility, from the referral site, this patient was transfused with blood. So I would also think of transfusion related to acute lung injury, which may have caused the desaturation in this patient. Like we discussed, the hemothorax was definitely there because there's a chest tube in situ and findings on the chest exam. Again, sepsis in view of polytrauma and being febrile. Yes, these were our differentials in that order. On the labs, this is the CBC that was done. It was
Dr.
unremarkable
Anit?
for the W. Yeah.
Dr. Anit, kindly just give us the positive findings from your labs. You don't have to read everything on the results.
Okay, so
Thank
the
you.
positive findings on the CBC were the low RBC count of 2.35, the low hemoglobin of 6.9, and a low hematocrit of 20.3. The rest of the findings on the CBC were unremarkable. On the LFTs and RFTs, we noted a high total bilirubin, a high total direct bilirubin, and a high GGT, indicating possible liver injury as well, which could be drug-induced or any other reason, which also falls in line with the patient being jaundiced. The urea was mildly elevated at 7.5. The other parameters like the ALT and AST were not mentioned here because the lab did not have the appropriate reagent to test for these. Moving on to the imaging on the next slide. So we have a chest X-ray that you can see, which is taken in the AP position, showing multiple rib fractures from rib 2 to 6 on the right side, a collapsed lung, and a possible pneumothorax as well. On the left-hand side of the slide, you can see the leg X-ray, the right leg X-ray, showing comminuted fractures of the tibia and a fracture at the distal portion of the femur as well.
This is to the audience. We want to run a poll. Emma, can you help us launch this poll? Yes, we're using 1 minute. What are the pathologies on the radiograph? I hope everyone got a chance to eyeball through it. Okay, so I have a 36% participation. This one now excuse people. It's exactly 1 minute. I'm going to end this poll. We shall discuss the findings. So, Dr. Anit, any other results to showcase?
Yes. So still continuing on the imaging, we had a pelvic X-ray also taken on this patient, which shows fractures at the pubic arch and a bit of dislocation of the pubic symphysis as well. And we also did a non-contrasted head CT scan, which obviously shows the mandibular dislocation, as you can see. And other than this, there are also there's also evidence of diffuse axonal injury in the brain, still seen on the head CT. And lastly, we also had a chest X-ray done after the chest tube was inserted, which is after the patient was brought in, which is on the next slide. It's not very clear, but you can appreciate the chest tube being in situ, still on the right side, with still the pneumothorax being seen. Yes. So our working diagnosis on this emergency was acute respiratory distress syndrome, secondary to polytrauma. So after our immediate interventions, our further course of management was for the airway, we planned for tracheostomy. However, the ENT team was a bit reluctant to perform it. So we planned on keeping this patient on the high flow nasal cannula at 60 liters per minute and an FiO2 of 94, with a target saturation of above 94%. Breathing, we'd repeat the chest X-ray like I showed you. We would repeat the lung ultrasound or the EFAST and still continue the patient on the high flow nasal cannula. For circulation, transfuse back red blood cells, ECG monitoring, maintaining fluids, and also give this patient IV furosemide, 80 milligrams. Disability, consult the orthopedic and neurosurgery team for the further way forward for this patient. Regular bed turning, again, as the patient had been non-ambulant, you don't want this patient to develop bed sores. NG tube for feeding and maintaining appropriate glucose levels. For exposure, still continue the paracetamol and IV antibiotics. Currently, we started this patient on broad spectrum, but like also how our expert pointed out, we'd want to be more specific on the antibiotics, for which we also planned on doing blood cultures up ahead.
Okay, thank you, Dr. Anit. Dr. Omar Rashid. This brings us to the end of our case presentation. The next session is going to be for Dr. Anit, just to let us know what were his take homes from his case. However, before he tells us his take homes from the case, I would like you to use the next 4 minutes to give us your pearls and pitfalls from this case. What would you do differently? What do you want this team that is attending here not to ever forget in case they ever get a patient like this? Yes, thank you. Dr. Omar Rashid, the floor is yours.
Thank you very much, Anna. So this is a very sick and a very complicated patient because so many things are happening. So the next time you see such a patient, consult as much as you can, because there is a need to consult oromaxillofacial about the mandibular fractures, CTS about the Blanchard's trauma, and then the EFAST, I think, didn't show any abdominal organ injuries, but it's also possible you could have abdominal organ abdominal organs injured. So you need to consult orthopedic for the bone fractures that are there. And then also we've seen multiple rib fractures. So it's also possible that we could be having a flail test going on here. And then we don't know whether this man aspirated maybe 4, 5, or 3 days ago, since he has been on the ward now for 5 days. So this is a patient you should not take lightly. We should get the kitchen sink and throw at him, get all your experts and have them sit down together and then make up a proper management plan. Because you might do everything to do with the mandible, you care for the chest trauma, you care for the blunt abdominal trauma, you care for the feeding, you care for the pneumothorax, you give the IV antibiotics, you give the pain medication, and you forget to give anticoagulation. And the patient will die because they got a thrombi, either a fat thrombi or a clot from the femur, and then the patient will die because of that. You're not turning the patient, and maybe you didn't give any anticoagulation to the patient. So this is not an easy patient to manage, and there are a lot of things happening. So be careful when you receive such a patient. What I don't want you to forget is don't ever forget to check the glucose for this patient, because you can do everything else and forget that this patient has not been eating maybe for the last 5 days because of the mandible fracture. And also the high bilirubin and the high bilirubin levels point that there is either an infective process going on or hemolysis going on because red blood cells are being broken down. So you need to get ahead of the infection before the infection kills the patient. So turn the patient, give anticoagulation, make sure I give the right antibiotics, and then make sure shock and does not kill the patient, and make sure pain is well managed, because this patient is going to have a lot of pain because of the several injuries that the polytrauma that has been noted in this patient. So that is what I can communicate to the audience. Thank you very much for listening in the interest of time.
Thank you, Dr. Umar Rashid, for those take-home points. Dr. Anit, you have 4 minutes to give us take-homes from your case. Yeah, please use them wisely.
Thank you. So to briefly talk about ARDS, it's a life-threatening pulmonary condition which usually occurs in traumatic cases, especially in patients with polytrauma and long bone fractures. And it leads to acute lung injury, progressive distress, refractory hypoxemia, and eventually pulmonary edema. Highlighting the traumatic causes here, they're listed: pulmonary contusion, chest trauma, fat embolism, transfusion related to acute lung injuries, hemorrhagic shock, multiple long bone fractures, burns, and aspirations related to trauma or altered consciousness. In our case, we thought of pulmonary contusions, we thought of Charlie. Our expert also thought of hemorrhagic shock. We had multiple long bone fractures in this patient as well. And again, there could have also been aspirations at the site of trauma as well. This is a simple flowchart highlighting the pathophysiology of ARDS. So following the initial insult, there's going to be damage to the capillary endothelium and alveolar endothelium, which allows protein-rich fluid to leak into the alveoli, impairing gas exchange, causing alveolar collapse and reduced lung compliance, which leads to oxidative damage. And since we have alveolar collapse, there's going to be impaired gas exchange, which will impair the ventilation perfusion ratios, which leads to the refractory hypoxemia, as mentioned earlier. And at the end, this leads to increased pulmonary resistance and acute cor pulmonale. So the main signs and symptoms you'd want to watch out for in a patient you would think would have ARDS would include shortness of breath, cyanosis, symptoms like fatigue, cough, fever, and confusion. And something to note is that these signs and symptoms may present between 24 hours to 7 days post-insult. And like we mentioned, that this patient presented with these symptoms on day 5 post the polytrauma, development of polytrauma, yes. Treatment approaches, we have operative and non-operative approaches. For the non-operative would be PEEP ventilation and steroids. And obviously to treat the underlying pathology or disease, basically the causative factors. Operative would be early stabilization of long bone fractures, such as the femur. In preventive measures, you would closely monitor the PEEP in these patients who are in fact at risk of developing ARDS. And you would also want to take serial X-rays to catch them early, and obviously allowing early interventions. Something to note is that even if managed in the ICU, ARDS generally carries a poor prognosis with about 50% mortality. With that, I'd like to conclude my presentation. Thank you.
Okay, thank you so much, Dr. Anit. Thank you everyone who has taken part in this session, who has been on our panel. We're going to quickly run through our post-tests. Again, this is not to make you feel like you got the questions right or you got them wrong. So the first question was, what were the possible imminent emergencies in this patient? And I think most of us got it right. We were able to mention that it was ARDS, PE, hemothorax, and sepsis. That most of us got well. And then the next question was the key emergency department management priorities for the patient. And this one equally, we performed so well on it. We were able to realize that we needed oxygen therapy, analgesia, and an antibiotic for this patient. And then the radiograph didn't do us so well. Most of us, but I think most people picked the bright part, which was the, let me see. We had the unilateral let me see. Well, I can't seem to move my that's a well. But we did have a pneumothorax on the chest X-ray. And then we had a bilateral pneumothoraces with collapsed lung margins. Yes. So, but most of us, I think, answered the consolidation. Yeah, but otherwise, thank you so much for actively participating in today's session. We were glad to have you around. Just another reminder, we do have these sessions monthly, and we welcome students from all angles because emergency medicine cuts across. We welcome the EMT students, we welcome the undergraduate, the postgraduate, and even those in practice who want to sharpen their skills. So in case that you do see a patient that is of interest for emergency care, please feel free to reach out to any of us. We're trying to get coordinators for each university. For Makerere, you can reach out to Katushabe. Should be in touch with us to share your case and also be able to present to us. Otherwise, thank you so much to Mabel, Anit, Dr. Umar Rashid, and to the entire CPC team that has taken part in organizing this session for this month. Thank you. Thank you. Thank you so much. See you next month. Bye-bye.
Thank you, everyone. Bye-bye.
Oh, Edgar is asking, King Caesar, reach out to Emma. Emma is on this poll. Emma? Kindly unmute, and someone is asking if they're from King Caesar, who should they reach out to? I think we reach out to Emma.
Yes, thank you, Dr. Ann. For all those ones who want to find out which university and who to reach out to, please reach out to Katushabe, Erica. She is in charge of the responses from all the different medical schools. Thank you.
Okay, so thank you very much. Feel free to leave at will. Bye-bye. Participants from Kenya. Do we have participants from Kenya? Yes, they are still welcome. We're going to share Erica's number widely so that she's able to be reachable too. Yeah, so thank you, everyone. Feel free to log out. And then, Emma, this is just offbeat. There were some questions that I think we may need to have a session on the oxygen delivery modes and how to do it. That question came up, but I feel we didn't answer it extensively. We might have to find a way to close that. There was a back and forth on oxygen.
Yes, no worry, Dr.
On the podcast, maybe we should have to make sure that we cover it up.
Yes, we have the upcoming CPC podcasts that are coming up very soon. So these will be running after every session, and they'll be covering most of the questions that the chat has asked, and we feel like need to be deeply discussed by the experts and the team. So stay tuned to the podcast. We are going to be releasing them soon after every CPC discussion, and all your questions will be answered. Feel free to join in. They'll be pre-recorded such that you can always have a listen in anytime you feel like. Thank you very much.
Okay, cool. Thank you everyone for joining in. I'll close this session. Bye. See you next month.